So picture a hospital room at 2 in the morning. A patient is just, trying to get out of bed to use the bathroom.
Right.
And it seems like a completely simple moment. But the most dangerous thing you can do in a hospital isn't like undergoing complex surgery or taking some experimental medication. It's actually that just trying to use the bathroom alone in the dark.
Yeah, I mean, it sounds like an exaggeration, right? But clinically speaking, it is absolutely true that one simple action triggers more injuries than almost anything else that happens on a medical floor.
Welcome to today's deep dive. We are jumping into a really fascinating stack of sources you brought us all about fall prevention in nursing. And the mission here is to explore how a concept that sounds like basic common sense, just stopping people from falling down, is actually this massive invisible web of clinical assessments and liability rules and shifting human behavior.
It really is an entire matrix of risk.
Yeah, and whether you're, say, a healthcare student prepping for your clinicals or you're just someone with an aging parent trying to keep them safe, understanding this hidden architecture completely changes how you view a simple trip across the room.
Definitely. And I think the most compelling part of this research, well, for me anyway, is discovering that almost every intuitive solution we've come up with to prevent falls historically.
The obvious stuff, right?
Exactly. The obvious stuff actually turned out to be incredibly dangerous.
Which is wild. And we are definitely going to get into those backfires. Some of them are just staggering. But I feel like before we can even talk about preventing a fall, we should probably agree on what a fall actually is.
You'd think that would be the easy part.
Right. Because looking at the World Health Organization, they define a fall as an event which results in a person coming to rest inadvertently on the ground or floor or other lower level.
Yeah, which sounds incredibly straightforward on paper, like you're standing up and then inadvertently you are on the ground.
Pretty black and white.
But the moment you take that definition and put it into a high-stakes, heavily monitored hospital environment, the reality gets remarkably complicated. Think about a scenario known in nursing as a controlled descent.
Okay, let me picture this. So this would be a situation where, like, a nurse or a physical therapist is walking down the hallway with a patient.
Right.
And the patient's knees buckle. They start to lose their balance.
Yeah.
But the staff member's right there, so they grab them and gently guide them down to the floor so they don't hit their head.
That is the exact scenario, yeah. And under the strictest reading of that WHO definition, you could argue that shouldn't count as a fall because the staff member controlled the descent and prevented an injury.
Well, yeah, they caught them.
Right, but most modern hospital incident reporting systems mandate that an assisted descent is officially documented as a fall.
Wait, I have to push back on that. If a nurse catches you, you didn't fall. You were caught. I mean, why would a hospital penalize its own safety metrics by counting a successful intervention as a failure?
Because for years, hospitals were using that exact logic as a loophole to vastly underreport their true fall rates.
Oh, I see.
Yeah, if a unit manager could just say, well, we caught them on the way down so it doesn't count, then the hospital loses crucial data about how often their patients are actually losing their balance. And that leads to this massive debate in geriatric research right now regarding near misses.
A near miss being when someone stumbles, almost goes down, but manages to, like, grab a handrail or catch their own balance at the last second.
Yes, and researchers are arguing that those near falls are incredibly vital clinical data. Even though they never reach the floor, a near miss is a glaring red flag.
It's a warning sign.
Exactly. It tells the medical team that the patient's physical capacity is actively failing to meet the demands of their environment.
And that actually brings up, I think, the biggest historical shift in how medicine views this entire concept. Looking through these sources, it seems like back in the 1980s and 90s, the medical field treated fall risk almost like a permanent medical diagnosis.
Yeah, it was a totally static label.
Wow. Right. You got evaluated when you walked through the doors. They stamped fall risk on your chart, and that label just followed you around for a week.
You were either at risk or you weren't, based on a single snapshot in time.
But treating fall risk like a one-time label is kind of like checking your car's tire pressure on January 1st and assuming it's safe to drive on the highway every single day for the rest of the year.
That's a great way to look at it.
Conditions change,
Okay.
right? The sources emphasize really heavily that fall risk is a highly dynamic state.
And the speed at which that state can fluctuate is exactly what makes bedside nursing so difficult. I mean, just think about what a patient goes through in a single 24-hour period in a hospital.
Right.
They might be prescribed a new pain medication that causes dizziness, Or perhaps they develop a urinary tract infection, which in older adults can trigger sudden and severe confusion.
Delirium.
Exactly. Or maybe they've just been lying in bed for 3 days straight, completely immobile. Every single one of those factors completely rewires their risk profile from the morning shift to the night shift.
So you really can't rely on the data you gathered yesterday to keep them safe today. But I mean, if the risk changes constantly, how does a nurse actually keep up with that? This idea of systematically checking someone's fall risk every 12 hours didn't just appear out of nowhere.
No, it didn't. It was born out of this collision between academic geriatric medicine and the practical realities of bedside nursing, starting back in the mid-1980s.
Okay, let's unpack this origin story.
Huh.
It starts with Mary Tinetti, a geriatrician at Yale, right? She published this foundational research proving that falls in older adults were not just random, unavoidable bad luck. They were predictable outcomes of measurable physical deficits. So she created the Performance-Oriented Mobility Assessment, often called the Tinetti test, in 1986.
And Tinetti's contribution was huge because she proved the multifactorial nature of a fall. It is almost never just one single issue.
It's a combination of things.
Exactly. It's an accumulation of small deficits, a little bit of muscle weakness, some slight vision impairment, maybe a side effect from a blood pressure pill. These tiny factors slowly stack up until they cross a critical threshold and the patient goes down.
But the problem was the Tinetti test was this very thorough academic evaluation. And bedside nurses simply do not have 45 minutes to run a complex mobility diagnostic on every patient, every single shift.
They needed something fast.
Right. And that's where Janice Morse comes in. In the late 80s in Canada, she developed the Morse Fall Scale because she realized nurses needed a tool that took 60 seconds, not an hour.
The Morse Fall Scale is brilliant because it boils the entire multifactorial theory down to just 6 rapid-fire items. A nurse looks at the patient's history of falling, any secondary diagnoses, their mental status, their gait, whether they use a cane or walker, and whether they have an IV line or a heparin lock in their arm.
Let me stop you on that last one, actually, because I think a lot of people outside of medicine might be confused by it.
Right.
I understand why using a walker or having a history of falling puts you at risk. But why does simply having an IV line in your arm make you a higher risk for falling over?
It really comes down to the physical mechanics of walking. When you walk normally, your arms swing naturally to counterbalance your stride.
Right.
But if you have an IV, you are suddenly tethered to a heavy rolling metal pole.
Oh, I see.
Yeah, you have to use one hand to push it, which completely alters your natural center of gravity. Plus, you have plastic tubing hanging down, creating a crippling hazard, and you're likely trying to navigate this bulky pole around a small, cluttered hospital room.
Which is tough.
So your environmental demand just spiked, while your physical capacity to balance is restricted.
That makes total sense when you break down the mechanics. It's not the fluid in the IV, it's the physical anchor you're dragging around with you. And this need for quick practical assessment led to other tools too, like the Hendrick II fall risk model in the early 2000s. And that one actually added this physical therapy-inspired get up and go test.
Right, where they actually asked patients to stand up from a chair and walk a few steps so the nurse could physically observe their mechanics rather than just checking boxes on a clipboard.
But having a good clinical tool doesn't automatically mean a hospital is going to mandate its use every single shift.
No, absolutely not.
The thing that actually turned these clinical checklists into mandatory universal hospital policy was a massive financial mandate. Specifically, the Deficit Reduction Act of 2005.
And if we connect this to the bigger picture, this completely shifted the landscape of hospital administration.
Yeah, because by October 2008, the Centers for Medicare and Medicaid Services, CMS, announced they were no longer going to reimburse hospitals for the extra costs of treating certain preventable hospital-acquired conditions.
Right.
And injuries resulting from inpatient falls were put right on that list.
Overnight, falls went from being viewed as, unfortunate clinical events to a direct, massive financial penalty for the hospital.
Here's where it gets really interesting, because it's basically like a local weather forecast suddenly becoming a legally binding requirement for you to install hurricane shutters on your house.
That's exactly it.
If you don't have documented proof that you checked the clouds and applied the shutters, you are financially on the hook for the entire cost of the storm damage.
Right. The financial lever forced universal compliance. The Joint Commission instituted national patient safety goals specifically around falls, requiring mandatory documented risk assessments. The clinical tools were ready, and the financial pressure just forced them into everyday practice.
Okay, so we have the mandated checklists, we understand the financial pressure,
Yeah.
but let's dig into the actual physical science of a fall. If we strip away the scorecards, what are the first principles here? The sources lay out three basic mechanisms, and the first goes back to what you mentioned earlier. A fall is a mismatch between a person's capacity and their environment.
Exactly. A patient doesn't fall simply because they are labeled old or weak. They fall when their available balance, strength, and reaction time fail to meet the specific physical demands of a specific moment.
Like trying to stand up quickly from a low bed to reach a TV remote that fell on the floor.
Right. On legs that have lost muscle mass from 3 days of bed rest, while slightly dizzy from a new medication, the demand of reaching for that remote far exceeds their physical capacity in that exact second.
Wow.
This is why true fall prevention has to target both sides of the equation. You try to improve their capacity with physical therapy, but you also rigorously lower the environmental demand. You put the bed in its lowest position, you ensure the call light is physically in their hand, and you clear all the clutter from the path to the bathroom.
Which feeds into the second principle. Risk factors are multiplicative, not just additive.
We see this constantly with something called polypharmacy, which is simply the medical term for a patient taking multiple different medications concurrently.
Which is incredibly common, right? Especially for older adults.
Highly common. So let's say a patient takes a standard medication for high blood pressure. That alone can cause a slight head rush when they stand up, a modest risk. But tonight, because they are anxious in a noisy hospital, they are also given a benzodiazepine.
A strong sedative used for anxiety or sleep.
Yes. Now you are combining a medication that lowers blood pressure with a strong sedative that severely dulls reaction time and coordination. The risk doesn't just add together, it multiplies.
Oh, I see.
If that patient tries to stand up in the dark, their blood pressure drops, their brain is too foggy from the sedative to process the dizziness, and their leg muscles don't react fast enough to catch their balance, the risk skyrockets exponentially.
And speaking of standing up in the dark, we have to talk about principle number 3, the single highest risk activity in a hospital. The sources indicate that a third to a full half of all inpatient falls happen when a patient is trying to get to or from the toilet unassisted.
It's the most dangerous activity on the floor.
But I have to ask on behalf of the listener, why? If you are in a hospital surrounded by call buttons with nurses stationed right outside the door, why are people getting up alone in the dark anyway?
This touches on one of the most profound psychological elements of healthcare. It often comes down to deeply ingrained pride, dignity, and embarrassment.
Oh, sure.
Most adults have been using a bathroom privately, without assistance, since they were toddlers. The psychological barrier to hitting a button and asking a complete stranger to come help you with something as intimate as urination or a bowel movement is massive. People simply don't want to do it.
They don't want to feel like a burden, or they're just embarrassed.
Exactly. So they convince themselves they can manage it alone. The clinical evidence supports this heavily, but the most actionable proof of how to fix this came from a major 2006 study by the Mead and Studer Group published in the American Journal of Nursing. They instituted a protocol called purposeful hourly rounding.
Meaning the nurses aren't just walking by, they are systematically checking in on a schedule.
Right. Nurses would do structured rounds every single hour during the day and every 2 hours at night. And they wouldn't just ask, do you need anything? They would specifically and proactively ask about pain, positioning, and toileting needs.
So they just say, I have time right now, would you like help getting to the bathroom?
Exactly. And by doing that, they completely remove the psychological barrier. The patient doesn't have to swallow their pride and push the button to ask for help because the nurse is already offering it as a standard, routine part of the day.
That's so smart.
Yeah.
And did it work?
The results were dramatic. It drastically slashed both fall rates and the use of the call light. They fundamentally altered the behavioral risk environment.
Okay, so if we know toileting is the biggest behavioral risk, and we know people will try to get up when they shouldn't, I have to play devil's advocate here.
Go for it.
If you have a patient who is confused, heavily medicated, and keeps trying to walk to the bathroom on a broken hip, why not just use bed rails or physical restraints to keep them safely in the bed?
Because intuitively obvious solutions have historically backfired in spectacular and tragic ways. For a large part of the 20th century, physical restraints like vests, wrist ties, or putting all 4 metal bed rails up so the patient was essentially caged in, were the absolute default response if someone was deemed a fall risk.
Well, I mean, it makes logical sense on the surface. If they can't get out of bed, they can't fall.
But rigorous research in the 1990s proved this approach was a disaster. Restrained patients actually sustained far more severe injuries.
Wait, really? How?
A confused patient doesn't just lie there peacefully, they struggle. They get entangled in the vests, which led to suffocation risks. Or, if you put all the bed rails up, the patient views it as a puzzle to solve. They try to climb over the rails.
Oh, wow. So instead of falling 2 feet from a sitting position on the mattress, they are now falling 4 or 5 feet head first from the top of the metal rail.
Exactly. The restraint turned a minor fall into a catastrophic head injury or a shattered pelvis. Furthermore, being tied down causes immense psychological trauma and deconditioning. Today, physical restraints are an absolute last resort in medicine. The formal, legal, and ethical standard is the least restrictive alternative.
Okay, so physical restraints are out. But what about bed alarms? Those pressure-sensitive pads you put under the mattress that beeps loudly if a patient tries to stand up. The sources point to a major 2012 study in JAMA Internal Medicine looking specifically at these alarms. If it beeps, a nurse comes running. That has to stop at least some falls, right?
The medical community assumed the exact same thing. Hospitals spent millions universally adopting bed alarms, viewing the alarm itself as a protective intervention. But this large cluster randomized trial showed that adding bed alarms did not reduce hospital fall rates at all.
Wait, zero statistical difference?
Zero. And the reason comes down to the brutal realities of hospital staffing. An alarm only prevents a fall if a nurse can hear it, drop whatever they are doing, sprint down the hallway, and reach the bed fast enough to catch a falling adult.
Which is not likely.
Right. Given real-world staffing ratios where a nurse might be 3 rooms away managing an IV pump for another patient, that instant teleportation is physically impossible.
So the alarm isn't actually protective, it's just an alert. It tells you a fall is currently happening, but it doesn't do anything to stop it.
It just creates noise, which leads to alarm fatigue for the staff.
And this brings us to what the sources highlight as the biggest misconception in practice today: the immobility paradox. There's this lingering idea that the best way to prevent a fall is to just keep the patient safely in bed for their entire stay.
Yes, which is so harmful.
I look at it this way: keeping a patient in bed to keep them safe is like putting your car on cinder blocks in the garage so it won't get into a crash. I mean, sure, it won't crash today, but the battery's going to die, the engine will seize, the rubber on the tires will rot. So a breakdown is absolutely guaranteed when you finally try to drive it down the street.
What's fascinating here is that analogy perfectly translates to human physiology. The medical term is deconditioning. If you keep an older adult in bed for 3 days for their safety, they rapidly lose significant muscle mass, cardiovascular endurance, and joint flexibility.
So they actually get worse.
Much worse. So when it's finally time to discharge them and they stand up to walk to the car, they are fundamentally weaker and far more likely to fall than they were the day they arrived. The modern mandate in nursing is safe mobility, not restricted mobility. You have to get them moving.
But that puts nurses in an incredibly difficult position. If alarms don't actually work, physical restraints are dangerous, and keeping them in bed makes them weaker. How do you actually use these risk scores? Because the sources discuss a massive ongoing debate right now between using universal precautions versus targeted interventions based on these scores.
Right, and the debate centers around the accuracy of the scoring tools themselves. Massive Cochrane reviews have shown that tools like the Morse Fall Scale rank general risk across a population moderately well, but they are actually quite poor at predicting whether an individual patient will fall on a given Tuesday.
Meaning a lot of people who score as low risk end up falling, and a lot of high-risk patients never do.
Precisely. So one camp of clinical experts argues, since the scoring is flawed, we should abandon complex risk tiers and just apply universal fall precautions to every single patient. Give everyone the low beds, the non-slip socks, and ensure the call light is in reach, regardless of their score.
And what's the argument against that?
The rival camp says, if we apply intense, heavy interventions to everyone, we waste incredibly scarce nursing resources and staff time on healthy 30-year-olds who don't need it.
So where has modern medicine landed? What's the middle ground?
Most modern hospitals use a hybrid model. Universal basic safety for everyone, and then escalating tiers of specific interventions based on their validated score. But the crucial takeaway in what they teach in nursing schools today is that a score is merely a starting point for clinical judgment, not a substitute for it.
It's just a guide.
Exactly. A high score just means you need to pay closer attention. And you have to look beyond age. An 88-year-old who is mobile and cognitively sharp can actually be a much lower fall risk than a 45-year-old recovering from spinal surgery who is just given a heavy dose of narcotics.
So if individual tools and alarms aren't silver bullets, how does a hospital actually keep people safe?
By treating fall prevention as an interconnected ecosystem, you have to look at the overlapping web of risk. For instance, we talked about confusion earlier. Many hospitals now bundle fall risk assessments with something called the CAM tool.
The CAM tool, what exactly is that measuring?
CAM stands for the Confusion Assessment Method. It is a rapid screening tool specifically looking for delirium. Delirium is an acute, sudden change in a patient's mental status. A patient might be perfectly lucid at breakfast, but by dinner, due to a mild infection or a medication interaction, they become highly confused and agitated.
Wow.
Yeah, they might forget they just had hip surgery and try to walk away.
So you have to measure their cognitive awareness right alongside their physical strength because a confused patient doesn't know their own physical limits.
Exactly. You layer the CAM tool with rigorous medication reviews from the pharmacy to catch that polypharmacy we talked about. This layered approach relies on James Reason's Swiss cheese model, which is foundational to patient safety.
The idea being that every safety protocol has flaws or holes, like a slice of Swiss cheese.
Yes. Under a just culture framework, a fall is almost never the fault of one single nurse. It is a system failure. The hospital sets up multiple slices of cheese staffing ratios, environmental design, medication screening, communication protocols.
Right.
But every layer has holes in it. A fall happens when the holes in those defensive layers happen to line up perfectly on a given shift.
And when the outcome is severe, like a fall resulting in a fatal brain bleed, that is what the accrediting bodies call a sentinel event, which triggers a mandatory, exhaustive root cause analysis by the hospital to figure out exactly how those holes lined up and how to shift the slices of cheese to prevent it from happening again.
It is a constant, rigorous evolution of system safety.
So let's bring this all back to you, the listener. How do these clinical frameworks translate beyond the hospital walls? What if you're just taking care of an aging relative at home?
Well, the beauty of studying this matrix is that the exact same first principles apply in your own living room. You start by looking for those compounding risk factors. You don't just write it off and say, well, mom's getting older. You say, mom was just prescribed a new blood pressure medication, and she has to navigate a dark hallway with loose rugs to get to the bathroom at night.
Capacity versus environment.
Exactly. So you fix the environment, you prioritize safe bathroom access, maybe installing motion sensor lights or getting a bedside commode for the nighttime. And you remember the immobility paradox.
No cinder blocks.
Encouraging safe, active mobility is vastly superior to wrapping someone in bubble wrap on the couch, which will only cause their muscles to decondition further.
And public health agencies agree completely. The CDC has a massive program called the STEADY Initiative, Stopping Elderly Accidents, Deaths, and Injuries, which is designed to take these exact same hospital principles, like medication reviews and environmental checks, and push them out into primary care clinics and living rooms.
Because falls remain a leading cause of fatal injuries for older adults. The hospital is really just a microcosm of the larger challenge we face as a society.
Let's quickly recap the journey we've taken today. We started with the realization that fall risk isn't a permanent label. It's a highly dynamic, fluctuating state that requires constant reassessment. We learned that the physical mechanics of IV poles and the psychological barriers of using the bathroom make simple tasks incredibly dangerous. We learned that the obvious solutions, like tying people down, relying on alarms, or keeping them in bed, actually cause far more trauma and weakness. And ultimately, we learned that real safety isn't a single checklist. It's an interconnected ecosystem of vigilance.
If I can leave you with a final thought to mull over, building on that push from the CDC to bring clinical safety into the home, we now know that hospital fall risk is so dynamic, it changes hour by hour based on medication, hydration, and just the simple need to use the toilet. As our aging population grows, and as healthcare pushes aggressively toward keeping people in their own homes rather than in facilities, how long will it be before our own smart homes and wearable technologies start conducting their own digital version of hourly rounding on us?
Tracking us in real time.
Exactly. Wearables constantly analyzing your gait for slight stumbles, smart lighting tracking how often you get up for the bathroom at night, algorithms scoring your daily fall risk, and adjusting the environmental demand before you even consciously realize your physical capacity has dipped. The future of fall prevention might be an invisible matrix built right into the architecture of your house.
That is an incredible thought to end on. An invisible safety net right in your own bedroom. Thank you for joining us on this deep dive.
Yeah.
The next time you wake up at 2 in the morning and swing your legs out a bit into the dark, I guarantee you'll look at the environment around you with a completely new perspective. Catch you next time.